So hello everyone, welcome to our Zoom meeting. And again, I would like to welcome the new fellows and hello to everyone who is attending this meeting and also welcome later for the recording. So I'd like to, first of all, congratulate all those who matched and all the best for those who are applying next year. And we are here to help. So without you, and I think Dr. Selma and her team, the purple team, will be presenting today. So when they are ready, they're gonna start. Dr. Selma, when you are ready, I'm gonna share the screen again just to go over the agenda.
All right, thank you so much, Dr. Nader. How is everyone? I hope you're having a good afternoon. So we're going to start off with a relatively common presentation within geriatrics. This is stroke and cerebrovascular accidents, and Dr. Ayman and ElNail is going to be presenting today. So Dr. Ayman, whenever you're ready.
Do we have Dr. Ayman on board or?
I think he's trying to log in. Let's see.
What we can do, we can jump to the second topic and then later when he joins.
I think he's using the old link. I'll send him the new link.
Okay, sure. Sounds good.
Apologies, everyone. We'll just give him another minute or so. If he doesn't come in, we can move on to the next presentation.
Sounds good.
Hello, everyone.
Hello, Dr. Ayman. Thank you for joining us whenever you're ready.
Yeah, okay. I'm going to share my screen. Is it clear?
I don't think that we can't see anything yet.
It showed
Try
me that
again.
the only one can share the meeting.
Yeah, try again, Ayman. Try again.
Okay. Okay. Thank you. So my name is Dr. Ayman, part of the Purple team. And me and Dr. Abdalla, we're going to present for you today strokes and cerebrovascular disease, highlighting some aspect on elderly. These are the objectives of our topic today. We're going to talk about the impact of cerebrovascular disease on older adults, the treatment of the acute ischemic stroke, and how to recognize a transient ischemic attack, and also prevention and management. This is the topic that we're being covered, highlighting also the pathology of ischemic stroke, and my colleague Dr. Abdalla going to highlight and discuss with you the hemorrhagic stroke and management. So here the impact of cerebrovascular disease, and these are the epidemiological and also and factors that associated with prognostic of cerebrovascular disease on elderly. The incidence of stroke increases with advancing age and approximately double each decade. And the leading cause of disability and death among older adults. And in 6 months after stroke, in those whose age higher than 65 years old, we expect that 26% are dependent in activity of daily living, and 46% have measurable cognitive deficits. So this is a major impact. And the fatality rate within 1 month of acute ischemic stroke is 20 to 30% across all age group. And the common medical causes of death associated with stroke are myocardial infarction, arrhythmia, heart failure, aspiration pneumonia, of course, due to oropharyngeal dysphagia, and pulmonary embolism. So ischemic stroke in general, as we know that stroke in general divided into ischemic and hemorrhagic, and ischemic account for 80 to 85% of the total causes, and the hemorrhagic 15 to 20%. So the majority for ischemic stroke. And knowing the cause of the ischemic stroke would help us in or guide us in the treatment and prognosis, and also how to prevent further attacks. So 27% goes to cardiac emboli, and 19% due to large vessel disease, and 17% due to small vessel disease, and 35% as we call cryptogenic or cannot be classified. So we're going to start with the small vessel disease. So the occlusion of a small penetrating vessels, usually due to one of those two pathological mechanisms, lipohyalinosis or local arteriosclerosis. I remember from the pathology that the vascular diseases that occur with age can classify, and we call it arteriosclerosis, can be classified to either atherosclerosis or Mockingbird classified medial sclerosis or arteriosclerosis. So lipohyalinosis, known as also hyaline arteriosclerosis, and it occurs for when the patient has uncontrolled hypertension for long period of time. And the local arteriosclerosis, we mean here by minor atheroma. So these causes in small vessel disease are typically less than 1 centimeter and termed lacunar infarction when it affecting the lenticular striae artery, the artery that branching and supply deeper tissue in the brain. And the most common syndrome of this lacunar infarction, the one that affecting internal capsule and causing the most common syndrome, is pure motor syndrome. And risk factor here, or we call it modifiable risk factor, hypertension, DM, smoking, hyperlipidemia, and the lacunar stroke can occur concurrently with other mechanisms of ischemic stroke. So someone can have both, like embolism plus coronary stroke can occur all together. Regarding large vessel disease, most commonly caused by major atherosclerosis or atheroma, and can cause progressive occlusion of cerebral vessels in the anterior and posterior circulation. Important point to note here that a patient usually with large vessel disease with atherosclerosis can have a history of previous transient ischemic attack because the occlusion is progressive until this atheroma breaks and cause total occlusion with thrombi. And as mentioned here, it can cause in middle anterior posterior cerebral artery or in the carotid artery. So it can be identified non-invasively with imaging technique like Doppler ultrasonography, CT angiography, MR angiography, or conventional angiography. And also it can be caused by the same modifiable risk factor, hypertension, hyperlipidemia, DM, and smoking. Going further to cardioembolic stroke, and it's important and potentially preventable cause of ischemic stroke, most commonly caused by atrial fibrillation, but also we should consider other causes like moral thrombus post-MI, infective endocarditis, patent foramen or Wail, if someone has DVT, but most commonly associated with atrial fibrillation, because associated with 4 to 5-fold increased risk because of thrombus formation in the left atrial appendage and cardioembolism to cerebral vessels. And cardioembolic stroke due to AF account for 25 to 30% of all ischemic stroke. And cardioembolic stroke often occur without preceding transient ischemic attack. If we put it in comparison with large vessel disease with atherosclerosis, here it's no previous history of transient ischemic attack or neurological deficit. Lastly here, cryptogenic stroke, which is ischemic stroke that doesn't have a clearly identifiable cause. And we should differentiate between cryptogenic and idiopathic. There's potential causes of cryptogenic stroke that you need to explore, not like idiopathic. So use brain and vascular imaging to assess the size of vessels involved occur first. Consider atypical causes of stroke such as vasculitis, like someone had SLE, coagulopathies, and mitochondrial disorder. And recently, like there's many papers that showed late onset of Milas-like syndrome, a mitochondrial disorder in elderly patient, like mitochondrial encephalomyopathy, lactic acidosis, and stroke-like attack. It could present only with stroke-like attack without the previous mentioned features. So also, because it could be caused by atrial fibrillation, intermittent atrial fibrillation, so it would be wise if we do prolonged cardiac monitoring to detect intermittent atrial fibrillation as a potential cause of cryptogenic stroke. So here, immediate treatment of acute ischemic stroke, you should do CT scan immediate for head to differentiate between ischemic and hemorrhagic. You should assess the severity and pattern of neurological deficit by using National Institute of Health Stroke Scale, and identify non-stroke causes of acute neurological dysfunction could be one of the differential diagnoses, such as migraine, seizures, and drug intoxication. So here, the National Institute Health Stroke Scale, and it's a prognostic features. And I want you to remember also another fact, it's used recently, it modified the management of stroke, used as prognostic, and it also modified the management of stroke. And briefly, how this scoring system works, it has different parameters, as you can see here: level of consciousness, best gaze, visual field, facial palsy, motor for arms, assist separately from motor for legs, limb ataxia, sensory, best language, dysarthria, extension, and inattention. It has a total score of 42, lowest score of 0. The lowest the score, the better the prognosis. This is how it works. Not like GCS. Here, no. The lower the score, the better the prognosis. And I can show you in mid-calc an example of how it works. Here, the level of consciousness, it take total score of 7. Can you see in the table? Here in mid-calc, the same scoring system. So let's see the level of consciousness of how this 7-point being calculated. The level of consciousness is subdivided into 3 assessment tools. The first one is to assess by taking history. If your patient is alert and keenly responsive, take the score of 0. If aroused to minor stimulation, take +1. Require repeated stimulation to arouse, take +2. Also, if he doesn't respond by verbally but to pain, will take also +2. And maximum score for this item is when the patient is unresponsive, will take +3. The other one, you asked your patient about the month and age. If the patient could answer both questions right, take 0. Answer one of these questions right, take +1. Couldn't answer neither of these questions, take +2. If your patient is dysarthric, intubated, or traumatic, or there's language barrier, will take +1. The highest score also goes for if your patient is aphasic due to the ischemic attack, will take +2. The last one, giving your patient a command to blink eyes and squeeze your hand. If the patient could perform both tasks, like will take 0, this is the best. If could perform only one, will take +1. If you couldn't perform neither of them, take +2. +2 +2 +3 is maximum, is +7. And this is how it goes. So patient who score less than 5 suggests very good prognosis out of all these parameters. And if your patient score higher than 20, suggests very poor prognosis and high risk of major complication. And later on, I will show you how this also scoring system affected the management plan. So acute care of the older stroke patient, you should optimize hydration with caution because you want to prevent cerebral edema, control blood pressure while avoiding hypotension, preventing DVT, detect and treat coronary ischemia, heart failure, and cardiac arrhythmia because this is the most common causes of death in patient having stroke. Start block acting or long-term antiplatelet therapy or oral anticoagulant based on the pathology that leading to your ischemic stroke, and normalize body temperature and body glucose. Here we are going to discuss the recombinant TPA alteplase. So we should consider that the patient, when patient present within 3 hours of neurological deficit, and CT confirm absence of intracranial hemorrhage because it's an absolute contraindication for alteplase. According to HA recommendation, prolongation of window to 3 to up to 4.5 hours or 4.5 hours for patient who's older than or less than 80 years old who have the National Institute Health Stroke Scale score less than 25 and no prior history of stroke or diabetes. So it became one of the parameters that you should assess to know if that your patient is eligible to prolong the window for using alteplase. Your patient is younger than 80 years old and has a good prognostic scoring system based on NIH, and also no prior history of stroke or diabetes. You can prolong the window to 4.5 hours. And also use alteplase require careful assessment by a clinician experienced in treatment of stroke because of its complication, because it carries 6% risk of intracerebral hemorrhage and usually among patients with severe stroke. So it needs careful attention. Here are the contraindication to alteplase. We have major surgery within previous 2 weeks, previous intracranial hemorrhage, systolic blood pressure higher than 185, or diastolic blood pressure higher than 110 mmHg, symptoms of subarachnoid hemorrhage, recent uncontrolled bleeding, coagulopathy, and thrombocytopenia, with also an INR more than 1.7. In some other resources, you can find additional contraindication. For example, intracranial conditions that may increase the risk of bleeding, like intracranial neoplasia, arteriovenous malformation, and aneurysm. And also, alteplase may be administered to patients whose blood pressure can be safely lowered with antihypertension to less than 185 over 110 mmHg, with the treating physician assessing for stability of blood pressure prior to administration. So we have some of these contraindications are absolute, and other of them, like relative, we can use alteplase if being corrected. Here, some articles show that effectiveness of using alteplase plus endovascular thrombectomy. In 4 recent randomized clinical trials, endovascular thrombectomy in patients with proximal large vessel occlusion of the anterior cerebral circulation provided significant benefit when treatment began within 6 hours of stroke onset, and this use with using alteplase before endovascular thrombectomy, and the benefits were seen after 24 hours with 50% reduction in NIHS score, as I said, it's prognostic, and at 90 days with improvement in functional outcomes. So it needs a well-established center. If it's provided, it could be beneficial for your patient. Here, trans-ischemic attack is defined as a brief episode of neurological dysfunction caused by focal ischemia to the brain or spinal cord that doesn't result in acute infarction. In the past, we used to think that any neurological deficit that doesn't last up to 24 hours, but based on new articles and evidence-based medicine, it's changed that less than 1 or 2 hours, because what defined here is that no permanent damage to neuron, because sometimes the neurological features could last, or the ischemia could last less than 24 hours, but could cause permanent damage. So it's either defined by imaging or tissue-based evidence that it's a temporary, not permanent neurological damage. And the TIA is also a major risk factor for subsequent stroke. Management following TIA. TIA symptoms should be evaluated emergently. Brain imaging, ideally with MRI, is important to determine whether there has been an acute stroke, and if one is found, its location and type. So a non-invasive imaging of the carotid arteries, EKG, and echocardiography are important to determine the most likely cause of ischemia, and initiate treatment for secondary stroke prevention based on the result of the evaluation. Here, the preventing ischemic, how to prevent ischemic stroke. So blood pressure therapy to maintain systolic blood pressure less than 140 mmHg and diastolic less than 90 mmHg for secondary stroke prevention, and for primary prevention in those with other risk factors such as diabetes. Statin therapy for primary prevention in patients estimated to have a high 10-year risk of cardiovascular event, based on HA guideline. And we use here the high-intensity statin therapy for those patients. Also, several studies have confirmed that a 2- to 4-fold increased risk of stroke in individuals with diabetes mellitus. So aggressive treatment for the modifiable risk factor, hypertension, hyperlipidemia in diabetic patient is crucial. Some research suggests that tight control of blood glucose level in a healthier adult with diabetes might reduce the risk of stroke, although the evidence for reduction of other vascular complications like retinopathy and nephropathy is more compelling. And also supporting cessation of smoking, which increase the risk of stroke as much as threefold. In this part also, long-term oral anticoagulation therapy is recommended for patients with valvular and non-valvular AF at high risk of stroke, the cardioembolic stroke, and low risk of hemorrhagic complication. For valvular atrial fibrillation, warfarin dose to target INR from 2 to 3. For non-valvular AF, also you can use warfarin or apixaban, edoxaban, rivaroxaban, beside dabigatran as an alternative. Consider aspirin for patients with non-valvular AF and low risk of stroke is a possibility too. And if possible, initiate oral anticoagulation within 14 days of the TIA or stroke in those with atrial fibrillation to prevent further attacks. Because the more TIAs you have, the higher risk you have strokes. Following non-cardioembolic ischemic stroke, aspirin is the mainstay of antiplatelet therapy for secondary prevention, because in non-cardioembolic ischemic stroke, the commonest pathology is atherosclerosis. The minimal necessary dosage has not been determined, it's patient-based, and other antiplatelet medication have not shown consistent superiority to aspirin based on strength of evidence. The sustained release dipyridamole combined with aspirin showed by clinical trials is very strong and beneficial. Clopidogrel alone could be an option if the patient cannot tolerate aspirin. Combining clopidogrel and aspirin show inconsistent evidence by research. In 2 large trials, no benefit was found for the use of warfarin over aspirin for secondary prevention in the setting of large vessel disease, including intracranial atherosclerotic disease, because this medication work based on the pathology. So the managing ischemic stroke, all patients with cerebral atherosclerotic disease, you should control and target modifiable risk factor and prescribe daily antiplatelet agent and statin. Regarding the patient who had atherosclerosis in carotid artery, patient with more than 70% of carotid stenosis and symptomatic is qualified for carotid end arterectomy, and patient with recent TIA or ischemic stroke and ipsilateral carotid stenosis between 50 to 69% also qualified for carotid end arterectomy. But if a patient is with more than 70% stenosis and asymptomatic, you can consider carotid end arterectomy or endovascular treatment with carotid artery angioplasty and stenting, but only if the perioperative risk of stroke, myocardial infarction, and death is very low in those patients. Otherwise, you can go for carotid end arterectomy. Regarding cryptogenic stroke, the treatment, evaluate and treat modifiable stroke risk factor and initiate antiplatelet therapy. If a cardioembolic cause is suspected in your patient, like intermittent AF, it's wise for you to use prolonged AF or cardiac rhythm monitoring to detect this AF. If it's detected, you can go for an oral anticoagulant warfarin. And in the setting of a patient forming oval and venous source of embolism, oral anticoagulant is recommended too. And if anticoagulation is contraindicated in such patient, then an inferior vena cava filter or transcatheter PFO closure can be considered. This is my part, and my colleague Dr. Abdalla will continue with you with hemorrhagic stroke. Thank you.
Thank you, Dr. Ayman. Hello, everyone. This is Dr. Abdalla. I would like to present hemorrhagic stroke, intracranial hemorrhage. Intracranial hemorrhages account for 15% to 20% of all strokes. There is four main subtypes: intracerebral hemorrhage, subarachnoid hemorrhage, subdural hematoma, and epidural hematoma. The intracerebral hemorrhage present with abrupt onset of focal neurological symptoms, often associated with severe headache and vomiting and very high blood pressure and coma or decreased level of consciousness. Carries a higher risk for mortality than ischemic stroke and is best treated in comprehensive stroke centers. Emergent brain imaging, like head CT, is needed to determine whether a stroke is hemorrhagic or ischemic. Intracerebral hemorrhage. Acute care of intracerebral hemorrhage patient with systolic blood pressure of 150 to 220 millimeter mercury. To be lower systolic blood pressure to 140 millimeter mercury. Patient on warfarin. We treated by intravenous vitamin K and therapy to replace with vitamin K dependent clotting factor to normalize the INR. Patient with severe coagulation factor deficiency or severe thrombocytopenia, we manage by factor replacement or platelet as needed. All anticoagulant and antiplatelet therapies should stop in the acute period. Management following the intracerebral hemorrhage, control the blood pressure with a goal of less than 130 millimeter systolic and less than 80 millimeter diastolic. In patient at high risk of future ischemic cerebrovascular events, such as those with mechanical heart valve and prior ischemic stroke. Anticoagulation may need to be restarted within 2 weeks of the hemorrhage. In all others, withhold oral anticoagulation for at least 4 weeks to prevent recurrent hemorrhage. About subarachnoid hemorrhage is caused by rupture of intracranial aneurysm, 80 to 85% of cases, or another abnormality of cerebral vessel like AV malformation. Risk factor for rupture, size of aneurysm, older age, female gender, posterior cerebral location, enlargement of aneurysm over the time, prior subarachnoid hemorrhage. Patient with aneurysm at high risk for rupture should be referred to a neurosurgeon. Acute management of subarachnoid hemorrhage is similar to that of intracranial hemorrhage, but include surgical intervention and focuses on the detection and treatment of arterial vasospasm and common complication. Subdural hematoma is collection of the blood between the dura and arachnoid, usually due to head trauma, although the trauma may be mild, particularly in older adults. Approximately 15% of the cases is occur bilateral. Some older adults suffer from chronic subdural hematoma that may be symptomatic. The incidence of chronic subdural hematoma increases with age. About 50% of the cases has no history of head injury, and the other risk factor like clotting disorder and shunting procedure and seizure. The symptoms of chronic subdural hematoma like headache and slight to moderate cognitive impairment and hemiparesis and hemisensory loss. Some individuals develop the seizure or after subdural hematoma, with or after subdural hematoma. Treatment of chronic subdural hematoma, symptomatic or asymptomatic. symptomatics and the patient condition worsening. We remove the clot, maybe attempt. Asymptomatic or patient condition improving, we do clinical monitoring is appropriate because the hematoma may resolve without surgery. Choosing wisely. Recommendation based on the American Board of Internal Medicine Foundation. Choosing wisely. Campaign. Don't recommend carotid endarterectomy for asymptomatic carotid stenosis unless the complication rate is less than 3%. Summary. Cerebrovascular disease is leading cause of disability and death among older people. Acute stroke treatment can effectively improve outcome in patients, especially when care provided soon after stroke symptoms being and in multidisciplinary stroke center. Primary and secondary stroke prevention can significantly decrease the burden of cerebrovascular disease in older population. We have some cases to be asked to answer by any of you fellow. Case 1. A 79 years old woman a 75 years old woman has palpitation and shortness of breath. There is no history of cognitive difficulty or bleeding diathesis. Last winter, she fell in icy steps. On examination, irregular heart rhythm and no murmur. No evidence of peripheral disease. On the ECG, neo-onset atrial fibrillation and heart rate 78 beats per minute. Milligram per deciliter. So, the question, which one of the following is the most important to consider before ordering anticoagulation for this patient? Can anyone answer? Which of one of the following is most important to consider before order the anticoagulation? C. Someone typing C. C or B? Okay. Right. Not B. We monitor the renal function because, as we know, some anticoagulant need to monitor the renal function to. Okay. The second case, an 88 years old woman has sudden onset of deafness in her right ear, accompanied by intermittent episode of dizziness, during which the room spins very quickly. Symptoms began 2.5 hours ago. She has fallen twice since symptoms began, and she has walked into wall. History: the coronary artery disease, hypertension, cervical spine degeneration, disc disease, and no history of stroke or TIA or diabetes. Medication used: aspirin, statin, antihypertensive agent. She lives independently, uses cane and drives. So, which one of the following would be the most appropriate first step? Can anyone answer? Great. Thank you. we do the CT to exclude hemorrhage. Urgent CT. The last case, a 90-year-old woman comes for follow-up 1 week after discharge from the hospital, where she was treated for a right 1 centimeter basal ganglion or subcortical hemorrhage. She is accompanied by caregiver from the facility where she received physical and occupational therapy. Blood pressure on arrival at hospital was 220 over 106 millimeter mercury. At today's appointment, the caregiver reports that she tends to be sleepy and difficult to arouse in the morning, but otherwise is doing well. Her appetite is good. She has had no loss of consciousness, seizure-like activity, or headache. There has improvement in left-sided weakness. The history, there is coronary artery disease, hypertension, remote MI. She had been a heavy cigarette smoker but quit 24 years ago. Medication, in the 6 months before hospitalization, she had been progressively forgetful and may not has taken her medication as prescribed. Aspirin, levetiracetam, amlodipine, chlorthalidone, and metoprolol. And on examination, blood pressure is 116 over 86 millimeter mercury, and her heart rate is 60 beats per minute and regular. So, which one of the following is most appropriate next step in management? Okay, the answer is discontinue levetiracetam. Thank you. If there's any question, or Dr. Ayman, if you want to add anything.
Thank you so much, both of you. These are great presentations, and thank you for great job, Dr. Winsman. Go ahead.
Thank you so much, and thank you for the great presentation. I just have one question about target blood pressure on both ischemic and hemorrhagic stroke. On the presentation, it was like mentioned that the target systolic blood pressure was to drop blood pressure below 140, but I have have read that on one of my materials, the target blood pressure should be at 25% of the initial blood pressure in the first 24 hours. So can you please make that clear for me? Thank you.
Anyone of the speakers wants to answer?
Can you repeat the question, please?
My question was, it was mentioned that the target blood pressure on both ischemic and hemorrhagic stroke management is to drop the blood pressure below 140. But I have read on one of my books that the target blood pressure should be 25% of the initial blood pressure. So it's not recommended to drop it below that. So can you please make that clear for me?
Yes, okay. Great question. In both ways, because in the rapid drop in blood pressure, we're talking the 25% of droppage of blood pressure at the start. It's used for the highest target when the blood pressure is 220 or higher. So we decrease like 25%, not more than this, because we are worrying of in both ways, chemical hemorrhagic for this ischemia as complication, but overall target to drop blood pressure, not lower than 140. So in the first 24 hours, yes, 25% of the total, because the ischemia, you're rolling for ischemia, but overall target for your patient, because the patient will be admitted for longer time, not less than 140. Is it not clear?
Yes, thank you.
Thank you again. Any other questions? If not, we can move on to the next topic. Go ahead, Dr. Safa.
Oh, hi guys. My name is Safa. This is actually my first meeting, so I found it like I don't understand what this is all about. I understand the topic, but like I don't know what the schedule is, where the topics, if there's like plans or something. So could you please like explain more?
Sure. For all these new fellows, welcome. And then we will send you an email with some explanation as far as how the program works. So usually during this meeting, the Saturday meeting, we come together to discuss some of the topics that in academic, like in geriatric medicine, or other urgent issues, like when we have the COVID, we were talking about COVID, that's an urgent topic, or vaccination. And then part of this meeting will be dedicated to other skills that all the fellows will be able to obtain, and then try to improve. There are different aspects of that. So one part of the discussion also will be about the new projects or old research projects, that what's the updates, so that we can move on certain things. You will be assigned to a team, and your team leader will guide you through any further questions. So thank you so much for the question.
Thank you. I appreciate it.
You're welcome. Any other questions? If not, we can actually, Dr. Ahmed Lamir, go ahead.
Hello.
Yes.
I have a question. In the recent days, we encounter a lot of patients with a stroke, and there is no obvious risk factor like high blood pressure, hyperlipidemia, and other known risk factors that increase risk of a stroke. How to investigate this patient, and what should we do with them? And is there any rule to investigate to measure lipoprotein A in this patient or not?
Any one of the speakers wants to answer? I can follow up with the answer.
Okay, Regarding the question, yes, there's a lot. The modifiable risk factor account for the majority of cases of a stroke in general, but yes, there is inherited genetic factors that sometimes will present a patient. You can suspect that the patient has uncommon cause of stroke if the patient presents in younger age, like less than 40. The recent studies consider less than 30 years of age. Even if the patient has hypertension, will not be enough time to cause these vascular changes, the Ayman arteriosclerosis, because it needs longer time. You can think of AV malformations. MR angiography can detect some of these causes. And the lipoprotein A would be yes, it had a role in stroke patient. You can suspect it because it had a genetic factor. So you can ask the family history of similar conditions. You can find some of the families of the same younger generation. You can do genetic studying on these things, but that's why you go in parallel. You treat the patient acutely to prevent further complication, and you investigate from the commonest to the lowest common. But yes, the rule how to suspect these changes by going from the most common to the least common. And yes, you can find one case study reporting a cause. As I mentioned in my part, there's the mitochondrial disorders. As we all know, it present younger than 20 years of age, but they found that some patients present with mitochondrial disorders at the age of 60 and 70 at the first presentation. So you can expect everything. Thank you.
Thank you so much. Any other comments or questions? If not, we can jump to the next topic.
Okay. Hi. Hello, everybody. You can hear me, guys? My name is Wail Taha. I'm going to hello and Ramadan Mubarak for everyone. I'm going to present osteoporosis. Let me just first share my screen. I think I cannot share my screen, Dr. Nader. Could you allow me?
Now you have it. So try again, please. Thank
Okay.
you.
Yep. You guys can see my screen now?
Yes.
Okay, great. And I'm going to present osteoporosis, one of the common condition, especially in the elderly population. To begin with, let's start with the name of the osteoporosis. Osteoporosis usually combined of two parts: the osteo, which indicate for the bone, and porosis, which indicate for pores. So together, it's meaning the breakdown, formation of the bone, leading to decreased bone density, and eventually increase the fractures risk. By definition, osteoporosis defined by when the bone mineral density measurement of at least 2.5 standard deviation below the young normal adult reference. That means the T-score below 2.5. The presence of low trauma fracture of spine, proximal humerus, hip, and or forearm in those with osteopenia when the T-score is ranging from -1 to -2.5, and low trauma fracture and non-pathologic fracture occurring from a fall of standing height or less. And there is also WHO definition based on bone mineral density, BMD. In normal condition, the BMD should be not less than 1 standard deviation below the reference mean. In the osteopenia, the BMD usually more than 1, but less than 2.5 standard deviation below the reference mean. For osteoporosis, it's 2.5 or more standard deviation below the reference mean. And for severe osteoporosis, it's usually below 2.5 standard deviation of reference mean in the presence of 1 or more fragility fractures. Osteoporosis causes more hospitalization than ischemic heart disease, CVA, and breast cancer combined. So it's very common condition among elderly people. And it's more common in Caucasian and Asian American. And the mortality risk increased by 20% in the year after hip fracture. And that's common in male than female. And this risk persists for 10 years after hip fracture event. And those who had fracture event, the risk of future fractures increased by 2.5-fold. And usually 40% regain previous level of function after the hip fracture, but unfortunately 20% go and require long-term nursing home care. This slide gives us some idea and refresh our memory regarding the anatomy and physiology of the bones. On the bone, in the first picture on your left side, you can see how the structure of the bone, and in the left side, give you idea about the physiology on the bone remodeling, which mainly depends on serum calcium and parathyroid hormone, calcitonin, and vitamin D level as well. Usually, the bone remodeling and bone loss usually increase by age. So usually the spongy bone tissue replaced 3 to 4 years, and the compact bone usually replaced every 10 years. In women, bone mass increase from puberty to mid-20 to 30 when mass peaks, and at menopause, rate of loss accelerated for 8 to 10 years, then slower at rate 1 to 2% per year. Men bone usually loss started in 20s to early 30s, but it vary. And the cortical bone decline in women around age of 50, but usually it's around age of 75 in men. And usually it varies based on the sex hormone, age, and menopause as well. This is another slide showing the microscopic picture, and you can see the difference between normal bone and bone with osteoporosis, and you can see how the wide pores showing in the patients with osteoporosis, which could affect the bone mineral density in general and increase the risk of fracture in the future. There is many risk factor contributing to develop of osteoporosis. Those risk factor including intrinsic risk factor as well as some extrinsic risk factor. The intrinsic risk factor include genetics such as low birth size, late menarche, low childhood height and weight, sex hormones which include postmenopausal estrogen decline, and bioavailability of testosterone in men, skeletal loading, which include weight bearing provides level of beneficial stress, calcium and vitamin D deficiency. The extrinsic factors include smoking, alcohol consumption, poor nutrition and medication, as well as lack of weight-bearing exercise. There is also a list of medications also could contribute to osteoporosis. Those medications may include anticonvulsant like phenytoin and phenobarbital, carbamazepine, SGLT2 inhibitors such as dapagliflozin and canagliflozin, glucocorticoids, and usually work directly by decreasing function of osteoblast and indirectly by inhibiting the insulin growth factor 1 expression. Heparin, usually the mechanism of it, usually by directly decreasing the bone formation. The lithium by hypersecretion of parathyroid hormone. The methotrexate, the mechanism of action is not clearly understood. And PPI by decreasing the intestinal absorption of calcium. The selective serotonin reuptake inhibitors by inhibiting the osteoblast. TZD by inhibiting the osteoblast. The aromatase inhibitors by lowering the circulating estrogen levels. The glucocorticoids used, like I mentioned, is mainly drug used and mainly contributing the developing of osteoporosis, and the prolonged exposure to reduce the osteoblastogenesis and lead to low bone turnover. Fracture risk rapidly increase after in the first 3 to 6 months, and its progress with use. And it could be effective as long as low dose as 2.5 to 7.5 milligram per day could lead to increase the risk of fracture. Stopping decreases the risk, but unclear if it is retained to pre-exposure level. And there is limited evidence of use of large dose of high potency inhaled steroids on osteoporosis. So those cases who are under steroid, we need to check on their calcium, vitamin D level regularly, as well as BMD serial monitoring, and we need to start osteoporosis therapy as early as possible. There is another secondary cause of osteoporosis. This secondary causes of osteoporosis could include endocrine causes, such as insulin-dependent diabetes mellitus, Cushing syndrome, hyperparathyroidism, thyroidism, and hypogonadism. The other secondary cause also GI, nutritional and malabsorption cause, which include alcoholism, celiac, CLD, gastric resection, and IBD as well. Hematologic condition, which include multiple myeloma, leukemia, lymphoma, and thalassemia. Other secondary cause of osteoporosis include idiopathic hypercalciuria in 10%, immobilization, solid organ transplantation, also considered as secondary cause of osteoporosis, especially who's an immunosuppressant. So to do the workup to exclude the secondary cause of osteoporosis, we need to do some lab testing. Those lab testing include, we started with the CBC, CMP, creatinine, calcium, phosphorus, LFT, ALB, total protein, albumin. We need to check also on 25-OXD level, 24 urine collection of calcium and creatinine, parathyroid hormone and thyroid stimulating hormone, serum, urine, and urine protein electrophoresis to exclude multiple myeloma, tissue transglutaminase antibody to exclude celiac disease, urine free cortisol to exclude Cushing syndrome, testosterone in men to exclude hypogonadism. And in general, when the physical examination, in cases with osteoporosis, we need to check on height, weight, posture, mobility, and nutritional status, and build. Usually, the height loss more than 4 centimeter in women and more than 6 centimeter in men from peak young adult and adult height, and height loss of 2 centimeter in women and 3 centimeter in men status post previous vertebral fractures. The standard test for osteoporosis, we need to do the bone mineral density to establish diagnosis of osteoporosis and potent predictor of fracture risk. So the preferred method is DEXA. So a measurement of bone mineral density of proximal femur and lumbar spine. The femoral neck BMD is the best predictor for hip or other osteoporotic fractures. Other methods used for diagnosis of osteoporosis include quantitative CT, peripheral DEXA, and other tests, which is not commonly used in the United States. Measurement of expressed as measurement usually expressed as Z-score or T-score. Usually, the Z-score represent the patient's BMD to the expected one of the age and sex, and T-score compare the BMD to that of young normal adults of the same sex. Regarding the osteoporosis screening guidelines, the 2018 U.S. Preventive Service Task Force guidelines recommend that any woman 65 and above should undergo screening, and any woman below 65 years with increased risk of osteoporosis, as determined by a formal clinical risk assessment tool, also should undergo a screening. On the other hand, for the men, the current evidence is insufficient to assess the balance of benefit and harm of screening. And at the end, the NOF recommends screening all men 70 years and old, regardless of risk. And we do DEXA in both sexes 50 to 69 years with risk factor, such as a drug, illness, and history of fracture in over 50. And there is no additional benefit from repeat BMD testing at 15-year interval for healthy, older, postmenopausal woman with normal BMD with mild osteopenia. And usually the BMD done of L1 to 4 measure when making the decision about the therapy, vertebral or arterial or LN calcification and scoliosis, falsely increased BMD of AB spine. The BMD of proximal femur is preferred due to loss of osteoarthritic change. BMD of proximal femur is based on the BMD of total hip or femoral neck. And usually when you do the DEXA scan, you must scan patient in the same DEXA machine with consistent positioning. The vertebral fracture assessment also could be used as alternative method. Vertebral fracture assessment for diagnosis of vertebral fracture can be performed as a part of routine DEXA measurement and highly associated with future fracture risk morbidity, and commonly not clinically apparent and can be present in patients with T-score greater than -2.5. Treatment of patients with T-score greater than -2.5 reduced the further fracture risk. Vertebral fracture assessment has lower resolution than CT and spine radiograph, but has advantage of less radiation, lower cost, and more convenient. Repeat measurement should only be done for patients with recent height loss new back pain, postural change, or evaluation for medication. The indications for vertebral fracture assessment from the Internal Society of Clinical Densitometry 2015 position statement: if the T-score is less than 1.0 and one of the following, one or more of the following is present. If the woman is more 70 years old or old, and men for 80 years or are old, if there is historical height loss more than 4 centimeter, self-reported but undocumented vertebral fracture, or glucocorticoid therapy equivalent to 5 or more milligram of prednisone, or equivalent per day of 3 or more months. And this is the tools we use it for fracture assessment calculation. You to predict fracture probability, and by entering those data which include the age, sex, weight, height, history of previous fracture, parent fracture, hip, current smoking, glucocorticoids used, rheumatoid arthritis, secondary osteoporosis, and use of alcohol or alcohol consumption, and femoral neck BMD. When all those information entered, it's calculate the 10-year probability of fractures per percentage. Regarding the prevention and treatment of osteoporosis, all postmenopausal women and men 50 years old who meet the criteria by DEXA with history of hip or vertebral fracture or perineal fragility fracture. Osteopenia, like mentioned earlier, when T-score is -1 to -2.5, and high fracture risk, treatment uncertain. The NOF recommend treatment in those group if 10-year probability is 3% or more, or if major osteoporotic fracture is 20% or more, utilizing the fracture assessment tool. All patients may be counseled for osteoporosis risk reduction and receive fall prevention counseling. Also, reduction in fracture risk occur after 6 to 12 months after treatment. Treatment usually offered in anyone 1 year remaining 1 year remaining life expectancy, and usually general the start pharmacological treatment usually started after 14 days after the fracture. And this is some guidelines modification to reduce the risk of osteoporosis, such as encourage regular weight-bearing exercise at least 5 times per week for 30 minutes, encourage adequate intake of calcium, and encourage smoking cessation, counsel to avoid excessive alcohol intake, and usually regularly evaluate medication that increase the risk of osteoporosis. And usually the dose for most menopausal women of calcium intake for ladies more than 50 should be 1,200. And for men age ranging from 51 to 70, the recommended dose is 1,000. And the rule of thumb, the upper level should not exceed the 2,000 milligram per day. And usually the calcium carbonate is best absorbed with food, while citrate without food. This is the list of some medications which used for treatment and prevention of osteoporosis. This medication include bisphosphonate, which is the first line of treatment, and usually take orally in empty stomach. And the main side effects for bisphosphonate include upper GI symptoms, musculoskeletal pain, esophagitis, and acute phase response. and it's bisphosphonate usually is contraindicated in if GFR is 30 milli per minute or less. The other group of medications include RANKL inhibitors, such as denosumab, and usually this medication used as transition patient to the to other osteoporosis medication, and usually is given subcutaneously. And the main side effect of it lead to eczema at the site of injection, and also could cause hypocalcemia and increase the risk of infection, especially in the skin area. The other group of medications include the parathyroid hormone, which given orally, and usually not recommended to use for more than 2 years. And the potential side effect that associated with increased risk of osteosarcoma. The fourth group of medications used, selective estrogen receptor modulator and estrogen. This usually mainly used with the patient with breast cancer, prevention and treatment of breast cancer. And as you know, the risk factor include development of venous thrombosis and stroke, as well as flu-like symptoms and hot flashes. The second group of medications include calcitonin, which given usually intranasally, and usually it's not used at the first line of treatment because of risk of malignancy and limited efficacy. And the main risk, the main side effect of calcitonin include hypocalcemia, nausea, vomiting, as well as allergic reaction, and possible increased risk of cancer as well. The last group of medications include the monoclonal antibody agonist, sclerostin, and is usually those medication group not used by patient within 1 year of cardiovascular event because it's increased risk of myocardial infarction, stroke, and cardiovascular death as well. Okay. So as conclusion of that, choosing wisely recommendation. So usually we don't do routinely repeat PMD more than once every 2 years. And usually we don't perform population-based screening for vitamin D deficiency. Thank you so much. That's all I have. And thank you so much for listening. Thank you, everyone. And I open the task for any people who have any questions or any comment or anyone to add anything else. Thank you.
Thank you so much, Dr. Wail. This is a great presentation. Excellent. Thanks for the information.
Thank you, Dr. Nader.
Yeah. It's an important topic as well, both of them, stroke and osteoporosis in older adults. We need to know how they present and how to prevent them, and how can we help not only older adults, but younger adults also, so that we can prevent this from happening in the future. Any questions or comments? If not comments, Dr. Selma, are you still with us?
Yes, I'm still here.
All right. So we can switch the topics again. So Dr. Selma is accepted in a program fellowship, so congratulations. And I'd like to ask you if you can share your experience for the first one and then this one, if you can guide us as far as what step did you do, how did you come across these programs, and how other people can follow the same pathway. Before that, I think Dr. Mustafa has a question or comment. Dr. Mustafa.
السلام عليكم.
عليكم السلام ورحمة.
رمضان مبارك. It's Dr. Mustafa, BGI for Medical Research, Mohamed Medical Corporation.
Yes, go ahead.
I'd like to, first of all, thank you very much for his excellent presentation. I just have few comments and I want to add regarding the indications for DEXA scan. It's as he said, like one of the indications for DEXA scan is female more than 65. And I just remember a few more indications, like every patient who is on long-term steroid. What I mean by long-term steroid is more than 3 months defined in the guidelines. And as well as any patient with malabsorption syndrome, particularly patient with primary biliary cirrhosis. For those patients in particular, we need to repeat the DEXA scan every 2 years. For the rest of cases, there is no clear guideline on when to repeat the DEXA scan. As well as celiac disease and as well as, I think that's it.
Thank you so much for adding this comment. Or thank you. We appreciate your input. Any other questions or comments? If none, maybe Dr. Selma, go ahead. Thank you.
Thank you, Dr. Nader. Thank you so much. So just a little bit of a background. I moved here about 5 years ago, and I sat for my USMLEs and had applied for residency. I did not match, but I was looking at alternatives. So one other alternative is if you've done residency elsewhere, you can apply for fellowship. Whether it's in GME accredited or not program. So I applied for a geriatrics fellowship. I got in, nearly finishing it, completing it, excuse me. And I also moved on. I applied again to another for fellowship match as well, and moved on to a nephrology fellowship. And that's where I'll be going next. So the reason this is an alternative pathway for whatever reason, if you haven't, some people have applications that, might be an old graduate, you may have other sort of hurdles that could prevent you from matching into residency. And so this is an alternative pathway. And usually the programs just require residency from overseas, 3 years in a structured program. And that's pretty much it. In terms of being able to sit for your internal medicine boards, your ABIN, right now there are only 2 known pathways, which is either through residency or through an academic or research pathway. Fortunately, they're now looking at a third alternative pathway, which is to allow people who have done 3 years of fellowship in accredited programs to sit for their ABIMs. I think they're meeting this March, and sometime maybe later this year, they'll come up with a final decision, but there is a pilot study regarding this. So this is an alternative pathway. Also, there are other states like Tennessee, Alabama, where you can get your state license. And I also believe you can now be trained or observed by a senior doctor for 2 years, and then you can get your state license. So there are a couple of ways how you can go about this if you don't match into residency. And I think that generally the climate is changing with, people not as, applying as much, or we're having a deficit of physicians in the US. So I think things are changing rapidly. We'll start seeing a shift in how things are happening. But generally speaking, I think it's a good pathway if you haven't gone through the traditional one. If you have any questions or if you need assistance with anything, I'm more than happy to help. I'll also in the chat send a document, about the pilot study and, about alternative third route for ABIM. And I'm happy to help at any time. Thank you so much. If you have any questions, please go ahead.
Thank you so much, Dr. Selma, for sharing. So I'm going to just share with you also Dr. Samah Ahmed. I don't think she is in the meeting now, but she is one of the fellows who also applied for fellowship. And this is, I think, so this is when they send her like a conditional offer. So some of these programs, they're fellowship programs, like geriatric, infectious disease, nephrology, maybe others. They have some openings, and you can apply to them. And this is one of the fellows here applied to geriatric, and they offer her a position. There is another fellow also was accepted, and she found out that she was accepted to a residency program. So you can go either way. You can start your residency, and if you have trouble getting in the first time, or you apply the full time, and then there is the other option of applying for fellowship. So the requirements might be different, but basically they need you to have some experience, maybe overseas, if you did some work like residency or training, a couple of years in England, the Gulf area, whatever country you come from. If you have some experience, then if you have US citizenship, or if you have green card, if you pass step 3, this will indicate that you are on top of things. So they will most likely prefer you over other applicants. I think these are the basic requirements, and then they can do the interview, and if they have opening and you can match the requirement, maybe they will accept you. So this just, we want to share with you some aspects that people can seek or can find out about. If no questions, we can move on to the other part of the agenda. So if Dr. Sharifa, if you are ready.
Assalamu alaikum. Yes, I'm ready.
Okay.
And Ramadan Mubarak to everyone.
Ramadan Mubarak.
I can't share my screen.
Give me a second, just. Try it now, please. Thank you.
Okay. Can you see my screen?
Yes.
Okay, my topic will be Parkinson disease. We will talk about background and history, pathophysiology, clinical features, how to diagnose and treat special Parkinson syndrome. Background: Parkinson disease is a progressive neurodegenerative disease that results in neuronal dysfunction and neural loss in pathways of brainstem, basal ganglia, and cerebral cortex. Primarily a hypokinetic movement disorder. It's a second most common neurodegenerative disorder after Alzheimer's disease. Incidence and prevalence of Parkinson disease increase with age. In the United States, 1% are affected at age 60 and 3% are affected at age 80. History: it began in 1680. It's called Sylvius de la Boue wrote of an unknown resting tremor. In 1817, first description of disease by James Parkinson, known as shaking palsy. 1880, Jean Martin Charcot coined the term Parkinson disease and described variants of Parkinson disease. In period between 1920 and 1925, Papinski described additional motor fluctuation and pursued first-to-purpose damage to substantia nigra. At 1953, Greenfield and Bosanquet complete histopathology and brainstem delineation. In 1999, Contrusi, Kendert of New Jersey, and identification of PARK1 gene. The risk factors. Risk factor for Parkinson's disease, including age, environmental risk factor, and genetic, all play a combined role. Risk factor, pesticide exposure, welding as a profession, exposure to manganese, age, and family history. We have protective factors, smoking, and caffeine. Pathophysiology, complex neurodegenerative condition with incomplete understanding of the pathophysiology. Pathologically, there is a loss of dopaminergic neuron in substantia nigra, pars compacta, and locus ceruleus. Misfolding of alpha-synuclein, leading to development of Lewy bodies. We have other mechanisms like mitochondrial dysfunction, dysfunctional protein clearance system like ubiquitin protease system, autophagy lysosome system, and neuroinflammation. Clinical features. Parkinson's disease is associated with 4 cardinal signs. The first one, tremor at rest, unilateral at onset and remain asymmetric, most common in upper extremities and jaw. If absent, it will emerge after few seconds of outstretched posturing of arm. The second one, bradykinesia, progressive decrement or decrease in speech and amplitude of repetitive movement. Micrographia, slow speech and low volume voice. Rigidity, increased resistance to movement. We called it cogwheel rigidity with intermittent release of rigidity. Gait and balance impairment, slow, narrow pace and shuffling gait with associated reduced arm swing, stooped posture, and imbalance when turning. We have some videos here to show you resting tremor.
This patient has an asymmetric resting tremor consistent with Parkinson's disease. A resting tremor is a rhythmic oscillation of a limb that occurs at rest and diminishes with activity. It is sometimes described as pill rolling. Resting tremor is a cardinal feature of Parkinson's disease and usually presents asymmetrically in this condition. Resting tremor results from basal ganglia dysfunction. This can be due to either reduced dopaminergic output of the substantia nigra, such as occurs in idiopathic Parkinson's disease, or blockade of the postsynaptic dopamine receptors in the basal ganglia, such as occurs in drug-induced Parkinsonism.
The next video will show Parkinson gait.
This patient has a Parkinsonian gait with small steps, decreased arm swing, and unblocked turning. Note the resting tremor, especially prominent in the right arm. This patient has a Parkinsonian gait with small steps, decreased arm swing, and unblocked turning. Note the resting tremor, especially prominent in the right arm. Parkinsonian gait is a slow shuffling gait with short steps and decreased arm swing. Patients with Parkinsonian gait take many small steps to turn, known as en-bloc turning. They usually have difficulty starting and stopping. The characteristic gait with short accelerating steps is known as festination. Parkinsonian gait results from basal ganglia dysfunction. This can be due to either reduced dopaminergic output of the substantia nigra, such as occurs in idiopathic Parkinson's disease, or blockade of the postsynaptic dopamine receptors in the basal ganglia, such as occurs in drug-induced Parkinsonism.
The last one will show ataxic gait.
This patient has an ataxic gait. Note his wide base and unsteadiness. Patients with ataxic gait have a wide-based, unsteady gait with an uneven stride length. This is the gait disorder seen in persons with alcohol intoxication. Ataxic gait is usually due to dysfunction of the cerebellum, especially the midline cerebellum or vermis. This can occur due to structural lesions such as stroke or tumors, degenerative disorders, or toxic derangements such as alcohol intoxication. Another cause of ataxic gait is severe proprioceptive sensory loss. These patients do not know where their feet are in space. Sensory ataxia often improves with visual cueing.
Okay. Here we have non-motor symptoms. Cognitive symptom, bradyphrenia, slow processing, impaired short-term memory, and attention deficit with relative sparing of cortical functions, such as language, declarative memory, dementia. Affective and behavioral symptom, primary depression, anxiety, apathy, pseudobulbar effect, emotion incontinence, medication-induced psychosis, impulse control disorder, bonding purposeless stereotype behavior, dopamine dysregulation syndrome, craving for dopaminergic medication. Sleep-related symptoms like sleep fragmentation, sleep-wake reversal, rapid eye movement, sleep behavior disorder, restless leg syndrome, medication-related sedation and sleep attacks, fatigue. Autonomic symptom, constipation, postural hypotension, bladder and sexual dysfunction, sialorrhea, seborrhea, excessive sweating, hyposomnia, insomnia, impaired sense of smell. Musculoskeletal symptom, truncal and cervical stooped posturing, camptocormia, truncal flexion during standing and walking, frozen shoulder, dystonic joint deformities in hand and toes, and fall-related injuries. Pain-related symptom, painful dystonia and rigidity, mechanical pain, central and visceral pain. Diagnosis. To diagnose Parkinson's disease, we require to have presence of bradykinesia, this is the important symptom, and at least one of other cardinal feature and absence of red flag for an atypical form of Parkinsonism. A therapeutic trial of levodopa also can help when the diagnosis is in the question. Patients with Parkinson's respond well to levodopa. Brain imaging is recommended to rule out vascular disease and hydrocephalus. A dopamine receptor scan, such as single photon emission CT scan of brain using ioflopane 123 ligand, can be used as a confirmatory test, but not routine. Other testing, alpha-synuclein in CSF, PET imaging, transcranial ultrasonography of substantia nigra. Red flag for atypical Parkinsonism, dysautonomia, prominent orthostatic hypotension, urinary incontinence, impotence, inappropriate sweating. The most likely diagnosis is multiple system atrophy. The next one, abnormal eye movement, symptoms, supranuclear vertical gaze palsy, slowness of vertical skate. Alternative diagnosis is progressive supranuclear palsy. Prominent early cognitive impairment, dementia within first year of onset. Most likely it's dementia with Lewy body, but sometimes progressive supranuclear palsy or vascular Parkinsonism. Visual hallucination, early and not provoked by medication. Levodopa-induced hallucination can be seen in Parkinson's disease, especially in later stage. It's dementia with Lewy body. Early prominent postural instability and falls within first year of onset. The diagnosis most likely multiple system atrophy, progressive supranuclear palsy. If there is prominent gait ataxia, wide base gait with variable stepping, it's most likely multiple system atrophy. If symmetric or markedly asymmetric involvement in Parkinson's disease, characteristically asymmetric at onset and through its course, it's multiple system atrophy as well. If flake of asymmetry indicative of atypical Parkinsonism, it's multiple system atrophy or progressive supranuclear palsy. If there is a lack of response to levodopa as most important red flag of atypical Parkinsonism, its diagnosis will be multiple system atrophy, progressive supranuclear palsy, cortical degeneration, or vascular Parkinsonism. Management. Currently, no established medication can slow down the progression of Parkinson's disease, but daily exercise can improve gait and balance in some extent. Mainstay of therapy are dopamine precursor, levodopa, other supporting medication, peripheral decarboxylase inhibitor, carbidopa, to block peripheral effect of levodopa, like nausea, dizziness, headache. It can decrease with carbidopa. Dopamine agonist, pramipixole and ropinirole for patients less than 60 years who are at higher risk of dyskinesia. COMT inhibitor like entacapone, often used, and we rarely use tolcapone as it has liver toxicity. Monoamine oxidase inhibitor, acylglycine, raziglene, and NAMDA antagonist, amantadine, antipsychotic agent, pimavanserin, quetiapine. Side effect and management. We have immediate or acute side effect like nausea, orthostatic hypotension. We can treat it by increase the dose of carbidopa. Sleep attack, confusion, hallucination, dependent edema. Impulse control disorder occur with dopamine agonist, excessive gambling, overspending, or hypersexuality. Long-term effect, wearing off phenomena, loss of beneficial effect before next dose, increased frequency of dosing, COMT inhibitor, MAO inhibitor. Sudden off state unrelated to timing of medication, we can use inhaled rescue DOPA preparation. For dyskinesia, hypersensitization of receptor, can use amantadine. Dystonia, can use anticholinergic, but avoided in dementia. Medication-induced psychosis, we use pimavanserin. There is treatment, deep brain stimulation, a surgical therapy that involves the delivery of electrical stimulation to key brain targets such as subthalamic nucleus and globus pallidus interna. This type of treatment reserved for patients who show benefit from levodopa but have uncontrolled peripheral effect of refractory tremor. Parkinson plus syndrome. It's a combination of Parkinsonism with features that are atypical for Parkinson's disease and refractory to standard Parkinson therapy. We have three types. The first one, progressive supranuclear palsy, present with axial rigidity, ocular dysfunction, vertical saccade, facial dystonia, and dysphagia. Second type, multiple system atrophy, formerly Shea-Drager syndrome. It's present with dysautonomia and early fall. Cortico-basal degeneration, present with dystonia, myoclonus, aphasia, apraxia, and cortical sensory defect. We have drug-induced Parkinsonism, like dopamine receptor blockers, typical antipsychotic, atypical antipsychotic, and antiemetic, like metoclopramide, and dopamine depleter as reserpine. Uncommon drug that cause Parkinsonism, mood stabilizer, anti-epileptic, like lithium, valproic acid, and amiodarone, selective serotonin reuptake inhibitor. Here, document from medical archives, this book, an essay on the shaking palsy, released in 1870s. And here some pictures of posture and facial expression of Parkinson's disease. Thank you for listening. If you have any question or comment.
Thank you so much, Dr. Sharif, for this excellent presentation and informative session.
Yeah,
Any
welcome.
questions? Dr. Ahmed, please go ahead. Any comments or questions? Go ahead.
Thank you, Dr. Sharifa, for this great presentation. I would like to ask a question about the association between REM sleep behavior disorder and Parkinson disease. Does patient with REM sleep behavior disorder will end up with Parkinson in the future? And which subcategory of REM sleep behavior disorder is it more likely to increase the risk of Parkinson disease? Specifically, patient who suffer from sleep paralysis, does this patient will end up with Parkinson in the future? And thank you.
Let's back to the slides. So you ask about the association between Parkinsonism and REM sleep behavior?
Yes, REM sleep behavior disorder, like acting out during dreams, and specifically patient who suffer from sleep behavior disorder, sleep paralysis. Does this patient considered as REM sleep behavior disorder? And what's the probability of developing Parkinsonism in the future?
To be honest, I don't know the exact association between, but that all I know, it's like it's a symptom. Like, yeah, it's a symptom of Parkinson disease. So yeah, I don't know what's it's come first, if there is a sleep disorder and then the patient will develop the Parkinson disease. I have no clue in this. If anyone have, if anyone has any idea, can help us to understand.
I can interject if you don't mind. So specifically with REM sleep behavior disorder, more than half the people, the cause is unknown. And there is association, but it still has not been established. We just know that it affects like almost 240 patients of people with Parkinson's, but it's not a specific risk factor for like Parkinson's, but it's an association. And you also find it in other associations like multiple sclerosis or like medications like mouse, TCAs, fluoxetine. So it's a poorly understood entity. So far, they've only been able to associate it with certain neurological diseases and medications, but no specific cause has been found. So it's still like being studied. And that association, like I said, like up to 40% of people with Parkinson's have been found to have sleep behavior disorder. So that's my understanding so far of it. It's just a poorly understood field or entity. I hope that answers your question.
Thank you, Dr. Selma.
Thank you, Dr. Sharifa and Dr. Selma.
Thank you for the question and great answers. Any other questions or any other comments? If none, then we can move on to the last item on the agenda. Any updates as far as projects? Any new ideas, new research questions? Okay, Dr. Amel, please go ahead.
Hello, Dr. Nadir. Hi, everyone. Today, Dr. Esraa and I decided to share with you what we have done so far regarding the renal wellness, the new nephrology application that we are working on. So we haven't yet completed all the application, but we thought that getting a feedback at this point would be a great idea. Just let me share my screen. I hope you can hear me well because my internet connection is not stable today.
Yes, just give me a second. You can try now. Go
Okay,
ahead.
thank you so much. Can you see my screen?
Yes.
Okay, that's good. This is the first screen, or the screen that we have the logo and the name of the application. Of course, this is the MSU screen, which is a constant screen in all of our applications. So when the first two welcoming or splash screens are done, the user will review this screen. We decided in this application that we are going to do a new idea. In the previous applications, if you guys attended one of my presentations for my previous applications, the homepage is usually contains buttons, buttons that are stuck together, and each button has a specific action. For example, the first button is responsible for leading us to the homepage, and the second one to the information, and the third one to the patient's or user's profile, and so forth. But here we decided to create a new idea where we created a sidebar. First, before reviewing the sidebar, we just added some words about our applications, which is welcome to Renal Wellness App, your comprehensive guide to kidney health. Discover vital information on kidney anatomy, common conditions, treatment options, and practical tips for maintaining optimal kidney function. Empower yourself with knowledge and take control of your kidney health today. So after this intro, we just, the user has to click on the upper screen, the three dashes that you see here. And then this side menu will appear, and it contains the major constituents of the application, like the patient's profile, the diet, learn more, which is about the information, and the disclaimer, and finally the authors. So I'm going to start with my profile page. So here we added the information that we think it's important for CKD patients, especially end-stage renal disease patients, to share with their healthcare providers, and this includes the date the date where the data were added to the screen, and then the name, age, sex of the patient. Also, we have a component called dry weight, which is the weight we measure before doing the dialysis session for the patient. It helps us calculate the amount of fluid that is retained by end-stage renal disease patient. Also, we have the blood urea nitrogen, serum creatinine, serum potassium, serum phosphorus, serum calcium, and serum parathyroid hormone. And these are the most important information that patients with end-stage renal disease share with their healthcare providers. Let me get back. So here on the My Diet page, we initially we had an idea of calculating the amount of potassium and phosphorus that are present in the food that patients are taking, but this idea, unfortunately, was not applicable with the platform we are using. We tried so many times, but it was not realistic to do this without a programming language. So we changed the idea to another one. Here, if the patient clicks on this question, what have you eaten today? And for example, if I choose the first one, which is the beans pink mature seeds, and it shows the picture of that particular item, which helps the patient make sure that this is actually what he or she ate today. And then it shows the potassium content of 1 cup of that food item. I just forgot to add, this is 1 cup. So the potassium content in this item, for example, is 1,000 milligrams, and the phosphorus content is 872 milligrams. And then we added a certain formula that is calculated behind the screen. It will not appear in front of the user. It shows how much would 1,000 milligrams of potassium increase my serum potassium. For example, if my serum potassium is 5 millimole, if I ate 1 cup of pink beans, and this 1 cup contains 1,000 potassium, 1,000 milligrams of potassium, it shows that my serum potassium would likely increase by 2 millimoles. So I would go from 5 to 7. And we think this will help patients with end-stage renal disease regulate their potassium intake, because they usually have problems with this. It's usually very difficult for them to stay controlled. But of course, this is a rough estimate. This depends on many factors, on the metabolism of the patient, on the underlying kidney function, the urine output of the patient. So because this is a rough estimate, we have included an icon here just to declare this is not very accurate measure. So we said that please note that this is a general estimate, and individuals' variations in metabolism and potassium regulation can affect the actual increase in serum potassium levels. If I choose another item, the same way, it will show the picture of that item, the potassium and phosphorus contents, and by how much would my serum potassium increase. Yeah, so this is the idea of that page. There are more than 200 or 300 food items that we are planning to add. This is just for demonstration purposes. Yes, and these are the pages that we have done so far, but my team members are working so hard on completing this page, which is the information or the educational part that we think is very important for patients with chronic kidney disease or end-stage renal failure. So at this point, I will leave the stage to Dr. Esraa, our leader, because she has some comments regarding this application, and she has some questions also. So Dr. Esraa, please, if you are here, go ahead, please.
Hello, Dr. Nadir. Hello, everyone.
Thank you, Dr. Ahmad, for your effort on technical part on the app. I have some questions. So the first one, do you think it would be more beneficial to focus the application specifically to for end-stage renal disease patients, or should we include all chronic kidney disease patients?
First of all, thank you so much, Dr. Amar, for a great demonstration. So regarding the question, I think the approach should be with limited approach, like the end stage, with the idea that you can expand on the new version. So you demonstrate now your idea, try to apply it, complete this project, and then build on that. You can add to the early kidney disease people or acute kidney, whatever other groups. So you start with simple, achievable product, and then you can build on that.
Okay, thank you, Dr. Nader. I have other concern regarding the unit of measurement of chemistry investigations. So it differs from country to other. So do you think to include both measurement like milligram and millimole for the patient to accommodate user from different regions?
I think that might be a good idea, yes.
Okay.
The other option is might be a tricky. When they add their profile, they can, I think you did that, they can select their unit. It's like centimeter, inches. So they can select that, and this will be their default. So all your app in the background will use their preferred unit. This is another approach, but it might need some technical aspects. So the easier way is to do both of them. Yeah.
Okay, thank you, Dr. Nader.
You're welcome.
So that's what I have today. The other thing, so we need your opinion on the diet sections. Are we doing well on the diet page? For this page?
Yeah, I think you are doing great. And as Dr. Amel mentioned, if you list all the possibilities, then it will be, it's like when you go to the grocery shopping. So you have a list, and if you have all the items there, the patient may select whatever they ate for their breakfast or lunch or something. So it depends on how far you want to go. So I think if you complete the basic list of 200 items, 300 items, that will be more than enough. So.
Okay. Okay, thank you, Dr. Nader, and thank you, Dr. Amel, for your effort on this app.
Thank you so much, Dr. Nader, and thank you so much, Dr. Esraa, for being a great leader. So yes, we are planning to complete all the items, and also we will identify the formula of phosphorus as well, as we just identified the potassium. So yes, I think if we completed the menu, it's going to be a great application. Thank you so much, Dr. Nader, for the opportunity.
Oh, thank you for your participation and great work, and thank you for sharing. So this is how we can develop a certain mobile app that may benefit the patients or those who are suffering. So we can try to use this mobile app for education, for management, monitoring, and so forth. So thank you so much, Dr. Amel, for sharing, and your team and Dr. as well. So what I think we should do is we should focus on getting the product And then we can add some features later, similar to the iPhone. iPhone number one came with the applicability user, how they can find, and then they try to improve on the camera, the depth of the user on the application, and so forth. So usually the first one might be harder, and you will have a lot of ideas. You don't put all the ideas in your first version. Because you want to improve. So you set for version 2, version 3, with some added on or some new features. So thank you so much. Great work. Dr. Saida?
You're welcome, Dr. Nader. Thank you.
You're welcome. Saida, raise your hand. Go ahead. Or comment.
Dr. Esraa and Dr. Amel, I think it's a great idea to have that application. It will be so beneficial for patient use. So I just have 2 comments for you. If you have the basic data for the patient with chronic renal failure or end-stage renal failure, why you cannot individualize the percentage of increased potassium in diet or phosphorus or other items in diets based on the basic information that you have in the application. So it can be more specified or individualized rather than it's like rough estimation of exactly how much the patient ate in his diet and how much there will be increase in their serum potassium and serum phosphorus. And the second comment is the application including like a progression of the disease, like most of applications that's like health or wellness application, it's like they have a chart. So it's like the patient can periodically add the recent investigations, and then the application will show like a chart how he's progressing. So I believe it will be more beneficial if in case of early stage rather in the stage renal disease. So those are the 2 comments I just wanted for you guys, and thank you so much.
So thank you so much. These are great questions. So I think we can personalize according to the latest serum potassium and lab results of the patient. I'm not sure if we can predict by how much the serum potassium would increase if the patient, for example, ate 1 cup of a certain item. But what I know that like how many milligrams of a certain item that the patient can have, this one can be personalized according to the latest serum potassium test. So for example, if the serum potassium of the patient came back like 6, which is a high value, then the patient is allowed to take no more than 1,000 milligrams of potassium. And this is just an example. If it came back like 5, he can eat like more than that, maybe 1,500. So I think this one can be personalized, but I'm not sure if we can predict by how much would serum potassium increase. If Dr. Esraa, if you have any comments regarding this.
So I'm not sure that if I get the question right. So what we have on the application, when you enter items, then it will show you that the potassium content and the phosphorus content, and we have like a calculation for your serum potassium may be increased by how many millimoles. So every patient with end-stage renal disease are familiar with their normal ranges for their potassium and phosphorus, and I think this will be like more alarming for them. So if the specific item increases potassium by like maybe 3 millimole, it will be alarming for them. So is that your questions on this part, or?
My question was if you have the basic data of the patient's renal function entered already, so can you adjust the estimation of raising serum potassium and phosphorus level depend on what the patient ate?
Mm. So you mean that if we have the basic data for the like recent investigation for this month, if we can predict the cause of raising of potassium, like tracking for the patients?
Yes, exactly. Yeah, kind of like that. So if the patient ate, let's say he enter every day, like what he ate, or what he ate exactly, and how much potassium and phosphorus contain. So you can predict how much increase in serum sodium and potassium, potassium and phosphorus in his progression in general, comparing to his results or her
Yes.
results.
So regarding the tracking, so we start like this application by on simple ways. What we do now, it's make this information shared with the primary physician of the patient. So we didn't try to make like the tracking process. I don't know if we could make this, Dr. Amel.
Dr. Esraa, I'm sorry for interrupting you, but I think she means like, can you predict like by how much would the serum potassium increase for certain patients? Like now we give a rough estimate for all patients, but can we personalize this to each patient according to their profile in general? Like if a
Actually,
patient has, okay.
I see different application with those tracking process, but I'm not sure if we can do it because like I have like no enough experience and technical part on this, as you know. So I get her point, but I don't know if we could make this. It's a great idea.
Okay, thank you.
You're welcome.
Because
And
most of
regarding your,
applications-
sorry.
Sorry for that. Because most of applications, you know, the users love to go through tracking their health. So for example, like just regular pregnancy follow-up applications. It's like when you're giving the basic information about the weight, the height, and then each time you periodically add on that, it show you like a chart of how progression, like your progression of the weight gain and such. And if you go across the limit of the abnormal weight gain, that it will give you like alarm, you're going so far. So it's I guess it will be more beneficial for patient to tracking it like in that way. So just a comment. Thank you so much, Dr. Esraa.
Thank you so much for the comment. Yeah. Sorry, Dr. Esraa. So yes, that was your second question. Actually, yes, we can do something like that. We can track the patient's increase in weight and serum phosphorus, potassium, creatinine, and urea. We can track all that. We can do it like in a schedule or in a list. But I'm not sure if we can do a chart because we have tried in the past to do a chart in one of our applications, which is the blood pressure app. And actually we failed to do that. And I think this is because of the limitations of the platform itself. It's not allowed to do that in the platform, but we can do it in another way. If you get what I mean.
Okay, great. I'm just giving comments, but I have no experience in app development. I'm just app user. So that's great to know from you, Dr. Ahmed.
Yeah, thank you so much. And thank you for the comments. And your idea is actually great. And we are working on that.
Thank you so much.
You're welcome.
Thank you so much, Dr. Amel and Dr. Esraa. Any other comments, any other questions, or any other updates? So I'd like to thank all the presenters from today, and thank you, Dr. Selma, and your team for great presentation. Thank you, Amel and Esraa, for the demo, and I wish you all the best. thank you everyone for attending. And I'd like to thank those who will come later to look at the recording. Have a wonderful day. I'll see you next week. Assalamu alaikum.
Thank you, Dr. Nadir, and thanks the team. I like the app, so good luck with it. Thank you, Dr. Nadir, for all you are doing to help us. God bless
You're
you.
welcome. Thank
Okay.
you. Have a wonderful day.
Right,
Great.
thank you, Dr. Nadir.
Thank you so much. Have a good one.
Thank you. Thank you, Dr. Nadir.
Thank you, Dr. Nadir. Thank you, everyone.
Thank you, Dr. Nadir.
Thank you,
Thank you,
Dr.
everyone.
Nadir.
Thank you. Assalamu alaikum. Fi amatillah.
Thank you, Dr. Nadir. Assalamu alaikum.
Alaikum salam. Thank you.
Thank you, Dr. Nadir.
Thank you. Dr. Esraa, go ahead if you have a question.
I'm here.
Hey, Dr. Nawad, how are you?
No.
Good. I see one is raising, Esraa, I think, raising her hand, but I'm not sure if you have a question. Dr. Esraa. Maybe she did in the past. Okay. Dr. Nawad, any updates? Thank you again and have a wonderful day. Assalamu alaikum.